I looked at the program. There is some disturbance, I guess, from someone's microphone. If you can mute yourself. Uh, I looked at the program and I noticed that I was one of the few people who had a topic which is very, very broad. It's something that is very exciting, but I was unsure. Hello. And I was unsure how I would cover this broad topic within 20 minutes. But I'll try to give you an overview of my perspective of innovations. Basically, I have to look at the various approaches. Again, that's a very, very big and wide topic, unable to finish in 20 minutes, but some key points I would share to you. I bring you all greetings from the Apollo Group of Hospitals, my new home after 30 years at the Tata Memorial Hospital. The motto at the Apollo and of our chairman has been to give the best care to people from the country at an affordable price. And that is adopting whatever is latest in innovation. And there are many firsts in the technology that has been adopted by Apollo. Can I have my next slide? Now we know that cancer, the incidence is increasing. And if it's currently standing at 19.3 million per year and 10 million cancer deaths, it was 12 million in 2012, 18 million in 2018. So it's something that's increasing. 1 in 5 people develop cancer during their lifetime. 1 in 8 men and 1 in 11 women die from this disease. And at any given point, we have 50 million people living within 5 years of a cancer diagnosis. And this is latest Globocan data. So with a rising incidence and a very severe mortality, we need to have innovation to help us conquer or tame this. Now, the war against cancer is not new. In 1971, Richard Nixon, the then president of the US, declared a war against cancer. 40 years later, this war against cancer continues because there is a major cause of death caused by cancer. In 2017, 1,650 people would die of disease every day, and 168,000 new cases would be diagnosed. The war continued for 40 years, and then in 2016, Joe Biden, the then vice president, declared a new war, something that they wanted to innovate that could help us control this cancer disease. The next slide. Now, generally a common myth about cancer, I think we missed one. Can you go back up? Okay, no, sorry. Go ahead. So, generally, the common myth is that innovations are all technology and technique driven. It is true to an extent, but all these technology and technique driven innovations, they lack a significant change in control rates and survival. In Indu's panel, they discussed about robot, they discussed about SBRT, other things. They do improve to some extent, but at best, they help us improve the quality of life and decrease morbidity. Yet most of us believe that it is the hottest and most sought after treatment. And I think there was also a discussion on the proton. And again, there was discussions that the proton may not, some people said they would not send patients. So I think we need to titrate which patients of ours would go for which kind of innovation and which patients would benefit from that treatment. Can I have the next slide? So then in 2016, as I said, Joe Biden, who was then the vice president, declared a new war against cancer, subsequently got elected as president, and he reignited what we call the Cancer Moonshot with the White House leadership in its effort again to innovate and set a target of reducing cancer deaths by 50% over the next 25 years. As signed in December 2016, the US has authorized a staggering 1.8 billion to fund the Cancer Moonshot over a 7-year period. Can I have the next slide? Now, if you look at the Cancer Moonshot, the NCA had what is called a blue ribbon panel to give thrust on where we should innovate to help conquer cancer. I've listed these in bullet points on the slide, but if you see, I've highlighted them in different colors, basically to drive a point home that to have innovation, you have to have a holistic approach to cancer. Now look at the reds. The reds say establish a network of direct patient involvement, minimize cancer treatment's debilitating side effects, and expand the use of cancer prevention and early detection. You have to innovate in this sphere. Look at the greens. Create a translational science network devoted exclusively to immunotherapy. Develop ways to overcome cancer resistance to therapy. Mine past data and develop a 3D cancer atlas. So not only are we targeting treatment, we are also looking at data. That's also huge innovation, big data in cancer control. And then the greens, develop ways, intensify research on major drivers of childhood cancer, and so on and so forth. Can I have the next slide, please? But to me, if you ask what is most important in innovation, it is understanding the biology. And those of you all who are radiation oncologists listening to this, understanding the biology, innovative on how we would give radiotherapy to our patients. And here is a RAM. If the RAM had to be sterilized, and this is an old teaching, it's basically on the 4 R's of radiobiology. If you gave one shot to sterilize the RAM, you would burn the scrotal skin as well as sterilize the RAM. But then if you fractionated your radiotherapy, you could sterilize the RAM as well as save back the scrotal skin. So understanding the biology taught us about the 4 R's of repair, redistribution, reoxygenation, and repopulation. And innovation looking at biology that revolutionized how standard radiotherapy would be given. Can I have the next slide, please? But I think the biggest winner when you look at biology was the story of Glivec and chronic myelogenous leukemia. It started in the 60s when people noticed the Philadelphia chromosome in the bone marrow cells of CML patients. Subsequently, in 1973, researchers at Chicago found that chromosome 22 and 9 and exchanged bits of DNA. Work continued in 1980. They found that there was a translocation resulted in the fusion of 2 genes that created a new gene called BCR-ABL. Can I have the next slide, please? 86, we found that there was an abnormally active form of an enzyme called tyrosine kinase. Subsequently, at the Oregon Health Science Center, tyrosine kinase as possible targets was identified, and there was born in 1993 Glivec, which today has totally revolutionized the way CML is treated. So the biggest inventions, the biggest innovations don't come out of machinery. They come out of understanding the biology, and literature is replete with number of such cases of biology changing how we treat cancers. Can I have the next slide? Advancing the biology, one of the most ambitious projects looking at innovations in cancer research is the International Cancer Genome Consortium. Basically, looking at massively parallel DNA sequencing of tumor and blood of the same patient to discover germline and somatic mutations. So different countries had to look at these kind of mutations in 50 different tumors. And we in India were tasked with the force of looking at it for buccal cancers. As we get more genomic data, we will have more data to help us target better treatment, prognosticate and treat our patients wisely. Can I have the next slide? So towards this, it has been developed now towards precision medicine in medical oncology. Many drugs that are approved by the FDA and the EMA, it reveals that just a certain percentage of population change the entire study and get benefit of the drug. But really, it's a minority of the entire study population. If you look at all innovations in medical oncology, the number to treat for one to get benefit is normally about 10. So basically, precision medicine is a new innovation intended to tailor treatment personally for single patients. In the broader concept, they're looking at precisely tailoring therapies to subcategories of disease. This is possible because today genomics have become widely available and cheaper. And a classical example in innovations in this kind of precision medicine is lung cancer, where you look at different mutations of EGFR, ALK, ROS, etc. And this has happened now in various other things. Further expanding this genomic molecular is cancer immunoediting and gene editing. We know we've got two types of immunity, innate and acquired, and there are a number of targets, the macrophages, dendritic, phagocytes, neutrophils, NK cells, the T and B lymphocytes. So immunoediting and gene editing with the CRISPR technology is something that is being worked on, and hopefully in time to come would help us target many more cancers. I think the classical example of this gene editing is at present in cystic fibrosis of the lung. There have been advances in cancer as well, but the immunoediting probably, can I have the next slide, has translated into our journey on immunotherapy. If you hit, it will show the timelines, but I'm not sure in this PDF version whether it will happen. Can you hit on that and just show us the timelines of immunotherapy? I'm not sure it's not showing up. Ideally, the slide should have been advanced by the speaker because it's a little distracting. But I had various timelines to tell you how the immunotherapy journey came up to 2000 when we found the new immunotherapy drugs that showed benefit in melanoma and subsequently are now used for many, many solid tumors. Can I have the next slide? Another approach to innovations is drug repurposing. Basically, this is looking at drugs that are already developed, repurposing them to use cancer. And the idea of this is that you can avoid the preclinical and probably phase 1 studies as well. In any drug development, $2.3 billion is required from bench to bedside, and this is an average. So if you do drug repurposing, you probably would cut down on the phase 1 and the preclinical studies, decreasing the costs and the time taken to get it to the clinic. Can I have the next slide? And again, in innovation, there are multiple targets that people use for drug repurposing, and they're all listed here in the slide. There are various targets. Hot off the press now, last week, is the JAMA article on metformin for breast cancer using this oral anti-diabetic drug, presumably having number of functions, but probably the mechanism of action through the insulin pathway was what was postulated. but did not find benefit. But there are various others, and I've listed so many of them up there, looking at vascularization and other targets in drug repurposing. Can I have the next slide? Again, this may not play, but this is a surgical innovation looking at both the laser as well as the microlaryngoscope with the laser and the robot, both cutting on the supraglottic larynx. I don't think these videos will play, but could I have the next slide? Showing that robot has proven in many cancers to be useful and beneficial. And here I have put this endoscopic approaches to a cancer that I treat, and that is head and neck cancer. We look at the first column of look at the first column of microlaryngoscopy, the second column of nasal endoscopy, the third column of TORS, which is transoral robotic surgery and robotic thyroid across 4 functions of oncological safety, functional cosmetic benefit, complications, and cost effectiveness. And you can see there's a yes for most of it. Again, showing you that this minimal surgery, remote access surgery, not only in head and neck, but across the board has proven to be very beneficial. Can I have the next slide? Innovations in radiotherapy, there have been multiple, the way we fractionate, the way we do other things. But here I'm just showing you proton. I don't have to discuss with this audience the benefit of proton. Basically, it's a heavy ion. It goes into the tumor, decays at once. Unlike conventional radiotherapy, where there's a long entry and exit beam causing a lot of side effects. Can I have the next slide, please? And here again, this may not play because it's basically to show you the pencil beam technique on how the proton beam can act on the tumor, literally hitting each of these black dots in this pink cartoon that you can see at the bottom, and spray paint or dose paint the disease without causing side effects. Can I have the next slide? Or minimizing side effects. And multiple cancers, there are multiple benefits across various cancers. And again, a very, very busy slide. But if you look at the top box of pediatric cancers, you can see it has minimal effect on growing tissues and minimal or less radiation to normal tissues and across the various spectrums of cancer. So innovation with machinery, both for surgery and for radiotherapy, is something that helps us treat our patients more efficiently. Next slide. Protons also cause a significantly lower incidence of second primary cancer. And here is data looking at 558 patients with proton compared to photons from the Massachusetts General Hospital, showing a significantly, statistically significant lower incidence of second primary cancers. Next slide, please. But I think innovation should be something that best suits our need. And here is the Jaipur foot. There were various type of prostheses, but Dr. Sethi then did this Jaipur foot. And that's the kind of innovation that we need in countries such as ours. Can I have the next slide? Here is a study that we did when I was at Tata's, basically using a simple form of chemotherapy called metronomic chemotherapy, which was low dose chemotherapy. Case in point, a farmer, left panel showing an advanced pyriform cancer, given low dose metronomic chemotherapy. Look at the 4 photographs on the right panel showing near complete resolution of tumor. What is this metronomic chemotherapy? Next slide. It's low-dose chemotherapy. Metronome is an instrument that a musician uses to keep time to the music. You keep giving low-dose chemotherapy. It does not kill the cells directly, but it affects the blood supply. And again, this was a cartoon that would very nicely demonstrate this tumor getting killed with the blood supply slowly turning to black with each dose of chemotherapy. Can I have the next slide? So we did do a study when I was at Tata. I've just put the phase 2 study. And now can I have the next slide, please? Uh, we looked at a phase 2 study looking at conventional chemotherapy with cisplatin and combination chemotherapy with low dose methotrexate and celecoxib. Can I have the next slide? And here is arm A and arm B, more or less equally balanced for site and patient characteristics. Can I have the next slide? And if you look at the efficacy parameters, you can see that they're more or less the same, the progression-free survival and the overall survival. Can I have the next slide? The toxicity is much less when you give your patient low dose metronomic chemotherapy as opposed to standard chemotherapy. You can see that the side effects are much lower in the arm. Can I have the next slide? But most importantly, the cost varies between a few hundred rupees to thousands of more costly. Again, you can innovate with traditional medicine. An example that I've shown you with a Nobel Prize medicine winner in 2015, looking at a novel indigenous drug in China called artemisinin, which is used for malaria. Exactly the same, and DBT is funding a lot in innovation using local products such as haldi or curcumin, green tea, and antioxidants. Can I have the next slide? But we know that cancer, the incidence is rising and the mortality is rising. Innovations has really not impacted in a big way when it's only focused on the machinery and various other things that I have shown you. You can see the projections of WHO going all the way to 2013, saying that the incidence of cancer mortality will increase. Can I have the next slide? So I think we need to have a holistic approach in innovations and not only look at only machinery, not only look at fancy equipment, but focus on prevention. And we have innovations for tobacco control, for infections, which is the HPV vaccine, various diet modifications that we need to think of. We need to detect our cancer earlier, screening, strengthen our healthcare systems. And we've got a lot of studies from our country looking at low-cost screening for cervical and oral cancer with mortality as an endpoint being reduced. And I think most important, we have to innovate to make our patients have equity and accessibility to treatment. And it's not unusual that we have innovations, but really it widens the care gap because it makes treatment more costly and therefore does not help all patients to benefit from the innovation that we have. So while we innovate, we must keep in mind costs and see that patients all over the world can benefit from that. Thank you very much for your attention.